here, our Associate Professor of Medicine in the Department of Cardiology, and he's going to talk to us about nutrition in defense of humans, how nutrition can heal or hurt us. Thank you, Dr. Smith.
Thank you, Lena. So I'd like to thank first for everybody who came in the last academic day. I think it's difficult to listen to this, particularly when we are going to start a new academic year. But I thought you may wonder why Sorescu, who basically, when he sees new patients as a heart failure cardiologist, their patient's life expectancy by 6 months about 50%. And why would I talk about something that sounds more like prevention? I really think I'm going to first talk about the problem, how we got here in the last 40 years. I'm going to try to talk a little bit about food, about some evidence-based medicine of what we know or we don't know about this. And of course, this is going to just mostly scratch the surface, but I hope it's going to give you some direction, particularly on controversial issues related to the best diet for cardiovascular disease or prevent cardiovascular disease, treat cardiovascular disease, and help us live longer. And then hopefully I can tell you what I usually tell my patients. I do want to tell you this is actually a spin out of a lecture that I've been giving to patients for about 10 years. As a matter of fact, I have a formal lecture that is posted on YouTube called Sorescu the Rescue that has lots more details about how to do it and what I tell them. But I thought this time I'm going to discuss and talk to my colleagues about this. Hippocrates a long time ago stated that let food be thy medicine, or medicine should be our food. And an old 3,000 years proverb says, when diet is wrong, medicine is of no use. When diet is correct, medicine is of no need. And I want to see if I can convince you with the little evidence-based medicine we have about the healthy diet that this still applies today, or maybe more than ever. I'm going to start first by explaining to you why I thought it would be relevant to talk to my colleagues about this. This is a paper that came out a couple of years ago where cardiology fellows were asked whether they have had formal nutrition education. And 90% of them, they said they had minimal or no nutritional education during the fellowship training. Actually, I can confess I've never had any. And I pretty much can tell you almost every colleague of my age or similar will tell you the same thing. Of course, our patients expect that we are experts and they look up to us to tell them what to do. Of course, they get education from nutritionists or some other ways. Turns out that from these cardiology fellows who got no nutrition education, about 8% said they have some kind of expert nutrition knowledge. About 95% of them say, but actually, I think we should be able to do it and we should have that knowledge to tell our patients. So actually, we do want to be trained and learn appropriate dietary education for our patient and teach them. In terms of what we actually do, only about 20% really had somewhat of healthy nutrition, as defined that eating more than 5 servings of vegetable and fruits a day. So 1 out of 5. So we really are not trained. We really want to, and we actually are not doing it. So of course, the role of nutrition education in preventing or treating cardiovascular disease or any disease to begin with is going to be extremely ineffective here if we don't believe in it. And I think that's important. Why? Because if you look at all the diseases that we treat every day, really the majority of them are caused just by poor diet, 35%. Tobacco is a good 6%, alcohol, sedentarism, but really proper nutrition is the single most important that is preventable, that we can make a difference. By all means, I'm not an expert, so pretty much everything I tell you today is derived from one of these experts who actually, this is what they do for a living. And I call Michael Pollan an expert. He's actually a journalist who is extremely famous for the books he wrote about it, where he actually analyzed extremely scientific the data that is present there. That I found actually his books extremely educational and helpful for me to get the relevant expertise. Dr. Rob Elastic is actually probably the most well-known. He's a pediatric endocrinologist at UCSF who's basically studies kids who have metabolic syndrome and they're overweight have fatty liver and basically are your future grown up, with cardiovascular disease and diabetes. Has done this for over 30 years. Dr. David Ludwig is actually the equivalent from Boston University that studies the same. Dr. Esselstyn is a retired CT cardiovascular surgeon from Cleveland Clinic who has done a lot of research in the field. And Dr. Colin Campbell is actually a biochemist, nutritional biochemist who's retired from Cornell, who has published a China study. We'll talk about that. And Dr. Asim Malhotra is a cardiologist, a British cardiologist who has been very active in clinical epidemiology and cardiovascular disease, who recently actually, I believe, moved at Harvard. So the elephant in the room is really obesity, and this pretty much map of the development of obesity in this country shows that pretty much in about 20 years we have become obese in the 30% range, and notice that the hottest area are the southeastern states. 20 years, and this completely overlaps new onset diabetes. So basically, not only we got obese, but we also got morbidly obese. We actually have the disease. So then the question, this begs for question, what's caused this? Obviously, if we continue like this, we are going to become, instead of Homo sapiens, which is the wise human, we're going to become Homo opesicus, not necessarily so wise. Is this really genes? And we like conveniently to blame it on the genes, but we are not mice to reproduce every 4 weeks and change our genetic material every month. We're humans, so there is no generation issue here. As a matter of fact, we try hard to look for it. This is a paper published in Science a few years ago that no matter how hard we try to look for genes to explain this, only 1% of obesity and 5 to 10% of all diabetes are explained genetically by some gene that's been proving to do that. As a matter of fact, I would make a case that if it's not the genes, it's the environment. Also remember that genes do not express even there is some predisposition without the environment. So I'm going to try to hit today the elephant in the room. The elephant in the room, and I'm going to hypothesize to you, and definitely not originally, quoting others, that overconsumption of sugar, fat, proteins, what we call processed food, industrial food, for pleasure, designed by industry, is what's causing our issues in the large-scale society. This is not an issue only in states. A similar map exists now for India, China, almost every other place. Causes insulin-resistant diabetes. That's pretty much at the crux of every other illness that we encounter in a patient. Dementia, depression probably comes first. Hypertension, coronary disease, strokes, cancer, fatty liver, and basically being one of the early initiators of all this. If we actually, any patients who comes with any of these conditions that you see here, if they live long enough, we're all shocked that it is a matter of time we're going to have to treat the others too. As a matter of fact, most of my patients, they come through the heart failure part of it, okay? But if whatever I do, it gets them better out of heart failure and they live long enough, I promise you I have most of my patients who live at least 15 years. Now I can say that because I've been practicing as an attending for 15 years. I discover at least 2 or 3 different cancers. If they live long enough, they get kidney disease, they get depression, they get dementia, they get every single of these that we put here, and there are numerous others. But I think the single most important is maybe earliest in the disease is that whatever we eat leads to abnormality of the liver, fatty liver. That's pretty much the absolute requirement to get morbid obesity and morbidity or comorbid illnesses here. So they are not. One, although we know that one condition is associated with another, and they can aggravate each other, I think they're all caused by the same source. As a matter of fact, it's first time in 50 years that our life expectancy in this country is going down. All right, it peaked at about, in 2010, and lately we started to go down. That does not occur in Japan, for example, or in Canada. And if you were to look at what's going on, really, there in average, life expectancy in Japan is about 5 years longer, including the peak maximum life expectancy than here. Not only that, that they live longer, but they also live healthier. Coronary disease, only a third of what we have here, particularly in Okinawa, which is fascinating, both in males and in men and women. Colon cancer, way lower incidence, twice less in men, 3 times less in women. How about the prostate cancer, which is virtually 95%, and somebody who's a man who is older than 80 here. 4%. Breast cancer, 6%. And other cancers. So it's not just coronary disease, it's not just diabetes, it's also cancers. If you look like from that perspective, it's like, let's not try to be biased by one diet or another. Let's look at those humans who live long and are healthy. What do they eat? And we have those populations. There are a few left over. There are about 9. They're called the blue zones. And basically Okinawa, Sardinia in Italy, Caria and Crete in Greece, Nicoya Peninsula, Costa Rica, Papua Highlands, rural China, Hadza tribe in Tanzania, Indians in northern Mexico, Seventh-day Adventists, which are here, okay? And they have a plant-based religious beliefs in food intake. And of course, this is changing rapidly because even those are getting evaded by industrial food. So what do they really eat? I'm going to show you. But in general, they have a low calorie intake. In other words, they eat moderately. They don't eat a lot. They have high consumptions of vegetables. They have and legumes, fish, some meat, low consumption of dairy products, low fat intake. Particularly, they have a high omega-3 ratio compared to omega-6s, and high fiber intake. And they only drink moderate alcohol. What do we have here, according with our guidelines, is the famous food guide pyramid that's been enforced since 1982 by FDA, American Heart Association, American Diabetes Association. And don't know about everybody else, but I'm one of the few who actually, I believe the ugly truth about the dietary guidelines, they don't work. That's for sure. And I will give you examples. And of course, now we have an updated version. They simplified. They try to be a little milder on the processed meats. It really is not a major change. Harvard actually has a slightly different version that's improved. We think that is easier to read and also to be guided by. But the simple fact that everybody pretty much have their own guidelines tells us actually we really don't know what's the best way of doing it. But I will tell you what our guidelines, standard guidelines, do in our hospital. Okay. So this is a patient who is morbidly obese, is mid-60s, is a minister, came in the hospital with diastolic heart failure, about 30 pounds fluid overload, was on oral metformin and for type 2 diabetes as outpatient, with pretty well-controlled sugar as outpatient, with diabetes at 30 pounds. 5 days later, ready to go home. He tells me when we're around in the morning, hey, Dr. Sorescu, I'm so grateful that I got the nutrition education from your nutrition. She's been wonderful. I learned some really good ways in the last 5 days how to eat healthy, and I'm ready to go home and I'll change. And I look at his breakfast. Okay, what'd you order? Well, this is what, I understood, and they let me order from the menu. I want everybody to try to be a little critical about this. And you could say, that I'm making, I may be a little harsh, but let's try to say I'm a diabetic. What should be the proportion of carbs and starches according to our guidelines? Less than, about 40%. Well, how much do we have here? We have about 80%. That's actually according to the guideline, according to what we're allowed, according to the nutrition advices. I'm not, they're doing their job. They're actually applying the guidelines. They're not doing anything wrong. I'm just saying it. This is actually according to what they say. And really, we have here what I call 80% bad carbs, and I will prove it to you on this breakfast. And 20% bad meat, because this is processed meat, and plus the sodium. And I was about to send it home, but I noticed on the board that the sugar was over 400. I said, what's going on? Well, not only was on sugar was 400, but from zero insulin 5 days prior, he was on a total of 100 units of insulin. Unknown to them, me, my colleagues in our intermediate residents, they did their diligent job, started the patient on insulin. I said, how am I going to send this patient home on over 100 units of insulin in 5 days, and sugar is not controlled. So what I do? I figured this ain't working. All right, and I actually stopped all this. I told him, go back to what you were doing. He had my cell phone. For 3 days, we texted and called. He was back to his sugar level with no insulin immediately, just by going back how I was eating at home. I said, disregard everything you learn here. All right? Okay, don't do that all the time. This was a patient that I had very good follow-up, and I was keeping an eye on every day. But it's a serious issue. And try to be critical. Please pay attention to what your patients eat in the hospital and look at the sugars, and you will be shocked that applying everything by the rule with everything we know does exactly opposite to our patients who are in the hospital. So why are we here? So the reason why we're here is because about 40 years ago, there was a big discussion between Dr. Ansel Keys and two experts, and Dr. John Yudkin. Dr. Ansel Keys was a clinical epidemiologist at the University of Minnesota. Dr. Yudkin was a British, actually, physiologist in London. And they had two different theories here of what should be the best way to prevent heart attacks in terms of the diet. One is heavy cholesterol hypothesis, and based on you got to reduce the animal fat in your diet to improve cholesterol. The other one based on the famous at that time 7-country studies that Dr. Ansel Keys has developed and found the correlation between high cholesterol and heart attacks. And the other one says no, it's actually high intake of carbohydrates, processed particularly sugar, causing fatty liver diabetes and heart attacks. That's the main idea. And the one that actually won at that time and was actually Dr. Keys. FDA picked the winner, and after that we changed our diet and we changed everything what we do. The irony of it is Dr. Keys got to live to up to 102. And the last 30 years of life, he actually lived in the little village Piapi, which is where the Mediterranean diet originated, which is actually high fat intake. All right, and basically, also Dr. Yudkin was very fascinating. In 1972, wrote a small little book called Pure, White, and Deadly: How Sugar is Killing Us and What We Can Do to Stop It. And this was recently republished by actually Dr. Lustig, because he was fascinating, and when he was doing his research and reading this book in the 70s, that pretty much everything he wrote in the book predicted what's happening right now from epidemiologic standpoint in our country and across the world. So I think it's a fascinating. I bought it and I read it. It's absolutely fascinating what he wrote there. So yes, he lost back then, but his theories were right, at least by predicting what's going to happen. And let's see how we got to this two opposite hypotheses that low fat is the way to treat and prevent cardiovascular disease versus the high fat one. So Dr. Keys says, well, cholesterol, there were three main facts at that time that originated this. One was in his 7-country study showed that cholesterol intake correlates with the risk of heart attack. As a matter of fact, turns out when you look through the data, there was no control. And the statistical part and the scientific expertise of that now is completely denied. It wasn't really actually very accurate, done with the current standards of assessment. The blood, that time they also found, biochemists found that the total is not so much the total cholesterol, but there's good and bad cholesterol, LDL and HDL, and the blood LDL cholesterol turns out was correlated with risk of heart attack. Also, it became a fact that patients with familial hypercholesterolemia have early incidence of coronary disease, which is a fact, and there's no doubt that this is a serious issue for them. So therefore, we started to say, well, we need to reduce the animal fat, and we need to do something in order to prevent coronary disease. Now, Dr. Yudkin said, really, the high fat, and actually that would be, if you try to cut the carbs, then immediately you're going to go up on the fat. High sugar diet really is what causes cardiovascular disease and not fat. And lately we found that it wasn't just the LDL that really mattered. There are actually two kinds of LDL. There's a type A, large buoyant, that actually is not associated with coronary disease. The type B, dense one, small, heavy, oxidized particle that's associated with coronary disease. And believe it or not, the simplest test to measure that, even if you don't send it for MRI and particle analysis, which we very rarely do unless you're an expert in lipids, actually just measure the triglycerides to HDL ratio. So this is not total cholesterol to HDL ratio. It's actually triglycerides to HDL ratio. And that really sugar, he stated that sugar and processed carbs elevate small LDL and causes heart attack and diabetes. So let's see who was right at the end. It turns out that in the last 30 years, all our guidelines and everything we have done actually at the population level, we did a basically natural study where we actually did that, as a matter of fact, as a whole society. And let's see what we got us. Turns out the low-fat, high-carb diet is addictive, causes insulin resistance, pretty much led to exactly opposite to what Dr. Yatkin wanted. It causes weight gain, which is the main cause for obesity epidemic. It's promoted heavily by food industry to replace natural with addictive processed food. Causes more diabetes, worse insulin resistance, and higher of this triglyceride to HDL cholesterol. As a matter of fact, we get more heart attacks and strokes and high blood pressure. We did have some reduction compared to 70s actually in the new incidence of heart attacks. But that's actually purely due to reducing smoking a lot. We cut from in the high 40s and 50s. Now we're down to about 70 and 80%, and that was very effective. The highest incidence of new smokers now, believe it or not, is women and kids. So something we're going to have to deal with that later on. How about the high-fat, low-carb diet? What they do, they reduce insulin resistance. You lose weight. It's not addictive. It's more satiating, as a matter of fact. You can't keep eating fat forever. You're going to have to stop. But if you do the other stuff, you got your soda with your pizza. You'll keep eating pizza the whole day. If from healthy fat, if the fat is actually from healthy fat, we're going to talk about good and bad fats that we know. Reduces actually cholesterol and prevents heart attack, paradoxically. It does not raise glucose and insulin. And I can tell you anything I want, but to quote Dr. Robert Lustig, which this is what they say at University of California in San Francisco, in God we trust, everyone else has to show the data. Okay? So believe it or not, I'm not going to have the best evidence medicine you can imagine. As a matter of fact, I'm going to quote mostly 2 trials. And it is the sad truth that that's the best I can come up with. There are some others too, but probably all I can tell you, these are by far the best and the well documented and accepted, even by people who don't like this hypothesis. But this is the data for the 2 studies. One is secondary prevention trial, LION, diet heart. These are patients that had heart attacks. They just had the heart attacks. It was back in the, it was published initially in 1994 in Lancet and eventually in 1999 in Circulation. And basically, it was a study for anywhere between 2.5 all the way up to 5 years. Patient just had an MI. They were on some standard of therapy medicines back then, which including beta blockers and statin at about 30% of the patients. As a matter of fact, and they were randomized to keep whatever medicines you have. And some of them go on the low-fat AHA diet, and the others go on the Mediterranean diet, and basically higher fat and lower carbs, and there are some supplements like fish and nuts, and something will supplement the good kind of fats, basically. And they had to stop the study after 27 months because it was a dramatic reduction in overall outcomes, new MIs, cardiovascular disease, but really this and overall mortality. Turns out the most benefit in overall mortality was from preventing strokes. There was also, curious reduction in breast cancers, all kinds of cancers. There were a lot of other benefits there. The obvious was not the main outcome. Then maybe the best primary prevention trial, that means patients with high risk for heart attacks, cardiovascular disease, who were placed on Mediterranean diet versus low-fat diet. This is primary prevention. There was a clear also overall improvement in mortality, although the effects were more minor. And when you look at that was overall mortality, which you see the data here. This is the overall cardiovascular mortality, which was profound in the Alliance Diet Heart study. And guess what? If you want to lose weight and control your sugar, this is better for that too. Those are things that matter to our patients. And this will be the purple line here. And of course, there are some others where more or less accepted as a valid trials, but most of them they showed the same directions with actually Mediterranean diet being effective in actually preventing cardiovascular outcomes. So my question is, why dietary guidelines? And you can quote me on that. Maybe I'm the only one who says that they don't work. Everybody's got their own opinion about that. But let's assume that they don't, because if they did, we wouldn't talk about an obesity, diabetes, epidemic right now, cardiovascular disease, comorbid illnesses, and everything we talk about. As a matter of fact, the psychiatrists or neurologists called Alzheimer's diabetes of the brain. It is true. Actually, if you look and you study that at the pathology level, you get exactly what you see in the kidney, what you see in the heart, in the liver, so on and so forth, in the brain. So here's what I think was wrong. And again, this is quoting Dr. Robert Lustig. The hypothesis is that the calorie is a calorie. In other words, the liver will see it doesn't matter where the calorie is coming from, whether it's fat, sugar, or proteins, it's going to process it the same way. That is, calories in equals calorie out. If you do your exercise, you can eat whatever you want to do as long as you're neutral balance at the end. And that ignores the fact that the fats, carbs, and proteins coming from natural sources are actually metabolized by the liver completely different from the ones that come from calorie-dense processed food. As a matter of fact, ignores also our own body response to, or organs, to the excessive loads of processed fat, carbs, and proteins. Upon chronic exposure, we have evidence that upon chronic exposure to processed food, the liver changes phenotype to a fatty, pro-inflammatory phenotype in the liver. Same in the fat, it becomes pro-inflammatory. I'm going to show you data from our own research in the lab showing that we switch by just putting the mice on equivalent of a burger a day and a soda a day. Their heart, protein remodels to become a fetal phenotype, and exactly like you have some kind of cardiomyopathy or ischemic cardiomyopathy. So the phenotype, you have a different cell for each and every organ in the body that changes upon chronic exposure to this, even if you keep the same calories. Once fat expands in the liver, the fat cell changes too, and then when that cell changes, it dictates what we do. In other words, I created a monster inside me that wants only that kind of food after that. And that's what makes it extremely difficult. Our gut microbiome changes too. So let me show you a couple of examples that a calorie is not a calorie, okay? And these are by scientists who, this is what they do for a living. So this is a simple 1 meal intake. You take a certain meal with certain amounts of carbs and starches and proteins, and we can give it having the same amount of calories and the same percent of carbs and starches and fat as a processed carb, or what you call refined, or unrefined, okay, which will be fruits, vegetables, whatever you want it, okay? And then you measure the glucose over 5 hours. You measure the insulin over 5 hours, the adrenaline activation, and the hunger activation, all right? So if you give the one with the refined carbs, you get a big spike of glucose that eventually will reach back to normal within 2.5 hours. But notice what's happened. This little thing, that area under the curve, it goes actually overshoots, and the sugar gets a little lower, all right? You don't have to be dying from that hypoglycemia, but you become symptomatic from it, and you'll see why. You become symptomatic because look at this insulin resist. If you do it without refined carbohydrates, you don't have that overshooting, and you have less glucose with area under the curve. If you do it, if you look at the insulin, way more overall total insulin release. This, which is less than without refined carbohydrates. This is the same amount of calories and the same ratio of carbs versus fats versus proteins. And this excessive insulin release is not without consequence. Dropping the sugar below a certain level that our brain likes at 2.5 hours makes us immediately release a stress response, adrenaline, which will make us perceive we're hungry. Guess what? We're hungry again at 2.5 hours. We gotta eat because we feel hypoglycemic, so to speak. I'm sure each and every one of you has had at least one of those symptoms, at least as a student. And then what you do, you get your immediate sweet sugar intake snack, and then you actually get sicker about half an hour after you eat that, because you just wrapped up and you did the same thing. Now, if you ate, something else, there's more meat or nuts, It will be slow release. You don't get actually that hypoglycemic peak after that. So that shows you that calories, 1 calorie does not equal another calorie. Now, these are patients who are diabetic, okay? He gave exactly the same food. Whatever was the ratio between different, he just posted there, proportions between, the patient had a main meal and there was a salad. Measure the same insulin release, whether the patient ate first the salad and then the main course versus eating the main course and then the salad. He just switched the order of it. Okay, in other words, eating French style first, and as opposed to non-French style. Okay, and turns out the insulin resist with area under the curve was about twice less. By eating exactly the same thing, you just switch the order. All right, what does that do? Well, vegetables, particularly leafy vegetables from the salads have fiber. Job of the fiber is to trap carbs and starches, sugar, fructose, and not let it actually release into the liver. It goes down to the bowel and really feeds our own healthy bacteria from the colon. It is not supposed to be food for us. That's the protective part of actually eating natural fiber, and that's one of the mechanisms. So even switching the order makes a difference. So every patient has diabetes now, or they want to lose weight. I tell them, whatever you do, you gotta have a salad with lunch and dinner, and you start eating the salad first. It makes a difference. Now, the single most important, and probably the most important study in terms of nutritional mechanism, was published by Dr. Lustig and his colleagues, about a year ago, where he actually found how we get fatty liver. All right, fatty liver is NASH, number one cause right now in this country of liver cirrhosis. He took these kids that he has, they're overweight, they have fatty liver. He gave them meals every day for about 9 days, prepackaged meals. That's all they could eat. He had exactly the same calories, the same everything you can imagine, except one, the fructose was replaced, and the other one with regular sugar as opposed. And other than that, they have the same amount of calories and total carbs and everything else. By eliminating and then did MRIs that measure the total body fat, but also the fat in the liver, quantitative. By 9 days, basically, the fat in the liver almost disappeared by just eliminating fructose from the diet, maintaining the same load of carbs and starches, proteins, and fat. So, number one cause of fatty liver in this country is fructose. I would say number two, it's alcohol. It's metabolized the same way by the liver. He has actually a whole lecture how that happens to biochemistry. But this is extremely important, at least in our kids. That's their alcohol. So, and as a physician, at the end of the day, we prescribe statins, because they have been proven to do the job. But I would like to know how about the diet? What's the evidence and what can we do with that? Well, if we were to go for the cholesterol hypothesis that all it matters is the fat, turns out that correcting the high LDL, that means you place the patient on statin or with diet, and you get it under control to whatever, less than 100 or less than 70 that you want at goal, actually that only will prevent 16% of heart attacks. 16%. There are 84% that we're not affecting. If you have high LDL, the high LDL in elderly, particularly older than 60, so I'm going to be soon pushing that. I'm going to be 50 now. It turns out there is no association between high LDL and cardiovascular disease after age 60, older than 60. And if there is anything, is the opposite relationship with mortality. The low-fat calorie, actually restricted diet does not improve outcomes. They tried for many trials, many years, sponsored or not by the industry. It's never shown to benefit. 75% of patients who are admitted in our CCU with heart attack have normal total and LDL cholesterol. So I'm not saying cholesterol is not one problem, but it's the least of the problems, or we're not covering much here. However, 66%, the majority of them who are admitted with heart attack have metabolic syndrome. These are studies from UCLA. And again, I just quoted Dr. Malhotra because in his book just has a nice reviews of all the studies. They're unbiased. Now, if we go on the other side, the high carb hypothesis causing this, actually correcting insulin resistance, again, that includes full-blown diabetes, but also so-called pre-diabetes, which is a term that I cannot accept coming from our endocrinologists and diabetes specialists. To me, what can you be a little pregnant or more pregnant, or are you the pregnant or you're not? Okay, there is no such thing as pre-diabetes. It should be called diabetes that needs to be treated with diet because it is diabetes. If you follow all these patients 10 years later, they all have already neuropathy and then they have full-blown diabetes. I don't understand why we call it pre-diabetes. It's wrong. Insulin resistance basically is number one risk factor for heart attack and also risk factor for hypertension, stroke, and cancer. The high triglycerides to HDL ratio, more than 2.75, anybody uses that number? No. Is actually better predicted than MI than the total cholesterol to LDL ratio. And really, coronary disease is not just a fat issue or cholesterol issue. It's actually a chronic inflammatory disease that it's independent of cholesterol. Cholesterol is part of it, but it's one small part of it. As a matter of fact, this was proven as a hypothesis a couple of years ago where Dr. Ritker took patients who over 10,000 patients with cardiovascular disease with a target LDL at about 80, or where we need to be. They checked if their CRP level was elevated or too high sensitivity and treated that with to prevent inflammation with an antibody against interleukin-1 beta. And then at the end of the day, it turns out we did have a improvement in mortality of a dose of 150 milligrams once every 3 months after a few years. So this proves that even if your cholesterol is burned to nothing, you cause coronary disease through chronic inflammation. That you got to get to the bottom of what's causing that chronic inflammation. So now let's go back into statins, which we prescribe them as a first line for patients with coronary disease. Appropriate so. It's been proven. There's no doubt. I have a patient who comes to me, just had a heart attack, and I got to convince them, you got to take statin for the rest of your life. What do I tell them? Well, let's look, and you can say, well, if the patient asks me about diet, how about diet? Can you compare one with another? Do we have studies that compare one with another? Actually, we don't. We don't have those studies. But we do have something that we can compare with. Is you can assess each of those studies by a variable called necessary number to treat. How many people do I need to treat to affect an outcome? And that tells you. And of course, the lower the number, the more powerful that is. So if you were to look at the benefit of cholesterol, I'll tell them, hey, everybody thought that you need to treat 83 after a heart attack to save one. What happened to the other 82? I have a question for you. Let's look in the mirror. How effective are we with the aspirin, Plavix, and the statin? I know we need to go. I know we need to go high. The higher, the better. The question is, how much are we helping for the side effects we're causing and the cost? 1 in 32 helped in preventing heart attack, and 39, sorry. 1 in 125, yes, the stroke benefits too. How about if you don't have heart attack? Primary prevention, so this would be secondary prevention. No change in mortality. We have zero evidence. If you have high risk, not heart attack yet, put them on statin makes a difference. 1 in 60 help for primary prevention. 1 in 60 will prevent heart attack. 1 in 268 will prevent stroke. It's just not going to improve mortality overall. Why? Because 1 in 10 will develop, myopathies and they have to stop, and 1 in 50 will develop diabetes from it. And you may say some of them are better than others. It doesn't matter. You cause something that you're going to call a long term, and that's our patient. How about diet? What's the necessary number to treat for that? Okay. Actually, I always poll the resident and the students, and I give them multiple choice questions. I don't think I'm going to do this time, but you will be surprised. Lions Diet Heart study, when you compare that to the secondary prevention for statins, 1 in 40. All right, and these are numbers I did myself. It's very simple. You take the absolute mortality, without the treatment minus the absolute mortality with the treatment, and you reverse the ratio by 100. It's easy to calculate. 1 in 40. So this is already twice better than the statin. If that is correct, we had them one next to each other, which now would be considered, of course, unethical. 1 in 18, and remember, there were about a third of them that were on statins. 1 in 18 helped to prevent heart attack, at least twice better than the statins. 1 in 30 helped to prevent stroke. And when it comes to primary prevention, 1 in 100 helped in combined lives saved, heart attacks, and stroke. Okay, so still better at any level, whether it's primary or secondary. At least this is the only data we have. And these are the only studies we have. I mean, I think it's obvious that we need more studies. I would love to have firmer data, but we don't have them. So how about side effects? Necessary number to harm? Nothing. So, I always say, well, I wasted my life as a professional, never had an education about nutrition, and I feel like I need to study to learn that on my own. But I'm going to show you a little experiment we did in the lab. Uh, about up to about 5 years ago, for about 15 years, I was part of a lab. I did basic research. We, as a heart failure physician, noticed about half of our patients with heart failure have morbid obesity, diabetes, the whole 9 yards. We suspected that really it's not the obesity. That's just the elephant in the room. Is how you acquire obesity by eating the wrong stuff that makes a difference. Like Jolie said, quad may nutrient may destroy. She has a tattoo. What feeds me also, nourishes me also can destroy me. And we took a simple, I went and combined with our hepatologist back then, Dr. Anania. He is very interested and he's still interested in fatty liver. Say, hey, do you have a good model for that? And I say, yeah, we do this every day, equivalent of a burger a day for mouse and a soda a day, meaning high fructose corn syrup that you put in that diet. This is about, this is not 10 burgers a day. This is not 2. This is not 5, just 1. Now, mice are like humans, omnivores. But if you ask them what they prefer, they're actually vegetarians. But they can eat anything, all right? So we put them on this that's equivalent of 30% of fat, this trans fat and polyunsaturated fat. I'm going to call this the bad fat, with rare exception. Only omega-3s are healthy fat here, but there is no omega-3 in what we eat. Diet also included, equivalent of a soda, high fructose corn syrup a day. And others actually have published this, showing that within 12 to 16 weeks, mice get high cholesterol, very similar to what happens to humans, hypertension, gout. They're hungrier, they keep eating because fructose suppresses the ghrelin, which turns off your eating signal. Obesity, insulin resistance, and more than that, basically what I did, he says, well, you look at the heart, you look at the liver. So I look at the heart. So every 4 weeks, we harvest the heart and we did a whole RNA protein analysis. And guess what? These mice, by 16 weeks, they have fatty liver and they have early NASH. About 40% of their liver is replaced with fat. Okay. And, this is a relevant issue in our patients. Why? Because you cannot have coronary disease without having fatty liver. All right. Basically, it's almost 100% incidence. You have 3 vessel coronary disease. It's 2 vessel coronary disease. You're going to have 93% if you have 1 vessel coronary disease, 85% have fatty liver. So the problem is the liver that sickens everything else. That's where everything starts. And the liver is the first station from the GI tract. So to my surprise, within 12 weeks, we already start to see dilated cardiomyopathy in these mice by just giving them a burger a day and a fructose corn syrup for a soda a day. And they get about an ejection fraction equivalent moderate LV dysfunction in the EF about 30-40%. And it's dilated cardiomyopathy. And we don't have this study in humans, it would be unethical, but we have the reverse study in humans. People who, one way or another, they lose 100 pounds and they had MRI before showing LVH, RVH, or LV or RV dysfunction, you actually lose the 100 pounds, everything gets back to normal. So it's actually very, similar. And when I look at I'm not going to bore you with the RNA and protein analysis. Suffice to say, just look at the blue stuff here. We see markers of cardiac hypertrophy switching to fetal phenotype. What's fetal phenotype? Well, in fetal life, heart works under low pressure and low sugar, high sugar, low oxygen. That's what comes from mom after mom has been fed, right? So that's actually starving the fetal cardiac myocyte. It's a starving fetal cardiac myocyte that feeds at oxygen level is 6 times less, and sugar that mostly no fatty acids. So basically, this is actually, and they actually have an ejection fraction of 30%. But they can afford to do that because the pressure system is 5 times lower. Imagine like pulmonary circulation. That heart is not failing, works just fine. And that's what happens by just changing their diet. I get exactly the same thing. They get insulin resistance. Turns out that the cardiac myocyte is actually a starving cardiac myocyte. So as a matter of fact, we think we're eating more. We actually get obese, but actually it's a non-democratic distribution of the nutrients. Most of them go into the liver and to the fat, and actually the liver sends insulin resistance signals to the heart and the brain and tell them not to eat. You actually get cardiomyopathy. You of course get glucose intolerance. When I look in the heart, cardiac insulin resistance within 8 weeks. Again, this is tissue. You don't have a hemoglobin A1C that's elevated. This is very early in the disease. You actually, whatever those poor, we feed them, that equivalent of a burger, that's oxidized fat. We actually see immediately that it goes into their heart. They have oxidized DNA, they have oxidized lipids, and they have glycosylated hemoglobin in their heart tissue, and same in other tissues. So basically in 16 weeks, I was able to reproduce in these mice what happens in anybody who develops end-stage heart failure. It doesn't matter what's the etiology. Just by switching them to a burger a day and a soda a day. Okay, and this starving heart that we found is similar to a starving brain. So people who eat that and they get obese with morbid obesity, they're actually starving all the time, and I showed you that. And basically, I think it's a matter of time. I couldn't get the mice to check them for sleep apnea, but I'm pretty sure we could have found that out too. So then there are good fats and bad fats. So back then we think I can't really. As a matter of fact, we even gave them an ACE inhibitor, see if we reverse that, and wiped out completely. And the reason why we gave them an ACE inhibitor, captopril, was because we found very early, within 2 weeks, the ACE enzyme, angiotensin converting enzyme, in the heart tissue goes up tenfold and stays up the whole 16 weeks. We gave an ACE inhibitor, preventing and completely everything. But if I were to tell you, hey, as soon as you go to McDonald's, take your ACE inhibitor, tell mom to do that to the kid, nobody's going to take it. So then I thought, why don't I try to, what if we had some good fats back? So we work with, put fish oil and omega-3s in this. That's only 1% of actually the total fats that were there out of the 40%. And, then we did the study again. And guess what? Yeah, we got the Alios, fatty liver 40%. We gave them 2 grams, then 4 grams, 2 equivalent in humans per mice, for 20 grams mice. And to our surprise, it really dramatically reduced the fatty liver. This is, you see white here without proper staining. This is actually with staining for specific for fats, to show you that. And their cardiomyopathy in a dose-dependent manner started to improve, but cardiomyopathy did not improve until glucose tolerance improved, insulin resistance, and until the fatty liver actually improved at particularly the 4 grams. So in other words, whatever I was trying to do to fix the cardiomyopathy, I had to fix first the liver before my cardiomyopathy will get better. It had nothing to do with the heart itself directly. So that's extremely important here. Also tells me there is a dose-dependent effect. And we didn't go to 6 or 8, but it's almost irrelevant because in humans we don't really use more than 4 here. But bottom line is, simultaneously, as soon as I was like so excited, let me review the literature. Of course, in the same year, we had 2 major studies coming up in New England Journal in humans with high risk of cardiovascular diabetes. They didn't show any difference. Why we all keep talking about omega-3s being good? The catch was, those were actually, the pills that were given were actually, fabricated, and mostly from plant-derived omega-3s, which comes actually with lots more omega-6s, which actually are pro-inflammatory. And there was low dose, 500 to 1,000 milligrams, which is very different. But so we found, I think the studies are not there yet to do it the proper way. Hopefully somebody's designing and doing that now. I think we need higher dose, depending how people eat and how advanced they are in their disease. So in summary, data from our lab suggested that morbid obesity is a marker of cardiovascular disease. Cardiomyopathy associated with Western diet is related to insulin resistance, just like coronary disease and everything else. Treatment with omega-3s improve liver steatosis. So only changing 1% of the all bad fats to good fats made the major difference there, and is all related to the fatty liver. While the clinical trials in humans with low dose omega-3s and 6s have failed to show major impact in cardiovascular outcomes at this level. Now we do have, these are all comers, but when it comes to heart failure, that means low ejection fraction, we do have actually 2 positive studies, one in ischemic cardiomyopathy, one in the non-ischemic one, that show improvement in ejection fraction outcomes. But again, these are all comers independent if they have heart failure or not. So I told you what the problem is. We found something that works. Let's go back to our business. This is updated food pyramid. This is a sweet young lady who, according to our food pyramid, she can eat that every day. Okay? All right. So now, don't know your personal expert opinion. But I don't think anybody thinks that if you can eat that every day, you're going to be healthy for too long. Okay? And that's allowed. Okay? And really, let's see what our food pyramid leads to. What do we eat? If we were to just follow what it says there, what do we actually eat? And this has been done. It's been published. Basically, it turns out we eat altogether about 86% of what we eat every day comes from animal products one way or another, while the fruits, vegetables, and grains are only about 14%. Okay, but how about those populations of humans who live to be 100 years old? What's their ratio? Well, Japanese from Okinawa, these animal products, I'm not talking about processed version, it's only 6%. Sure, they eat some meat, but they're on an island. They don't have access much to that. They have some fish, meat, and eggs. They're not like, oh, I'm going to eat only this or that. They just eat what they have access to, but that's what they eat mostly. How about the Greeks in Mediterranean diet? 11%. This is actually the highest, protein intake from meat and fish from those 100 years living population. So whatever we are doing exactly opposite from actually what we know it works in humans. And I don't know, and as a matter of fact, everybody's obsessive. You switch to plant and all that. Well, you're not going to get enough protein. Who needs that? The World Health Organization says 5-6% a day is just fine. Okay, so that's a label and I'm changing number. We don't know that yet. All we know is that it can go much lower than you think, and vegetables actually have plenty of it. So now we did that. We applied that, and the consequence is our sugar intake has changed from equivalent of 1 can every 5 days back in 1822 to about 17 equivalent of Cokes a day. All right, clear. Cutting the fat increased our carbs, processed or not. And not only that, but it's addictive. You also get depression, and it's actually one of the main reasons why it's impossible to convince the patient to switch. They need it. It's empty calories is addictive. It's a lot of processed fat, trans fat, profile with omega-6s. Again, omega-6s are the backbone for arachidonic acid, which is pro-inflammatory. All our leukotrienes, prostaglandins that are pro-inflammatory come from that pathway. Platelet activation factor. There's very little good fat, which pretty much so far we only know about omega-3s and 9s, which comes from fish, krill oil, and grass, or animal who eat grass, and then we eat them. Lots of processed carbs, sucrose and fructose from high fructose corn syrup. Why? Government sponsors. Is cheap and it makes sense. And it lasts forever. You can transport it. It's excellent. But problem with that, it feeds the bad bacteria, and we change our microbiome. Well, really, fast food comes with alcohol too. Let's not ignore that. And sometimes too much. Lots of sodium, little potassium. Very different how we were from what we were eating 10,000 years ago, or until recently, up to about 200 years ago. Few essential minerals, lots of proteins, but not amino acids, essential amino acids. And how we got here is actually we did apply at the society level FDA, AHA, ADA guidelines based on hypothesis that cholesterol and animal-derived fat are bad, reducing them to 30%. Compensatory went up. We replaced that with processed carbs containing high fructose. We stopped cooking out of convenience and out of taste. And I'm talking about slow cooking. Nobody cooks anymore for more than half an hour from natural sources. And I will explain to you why that's important, because cooking at low temperature preserves everything and doesn't cause disease, as opposed to cooking at high temperature. We actually been taught and trained. Everybody knows the best steak you can obtain, put the fire maximum at 500 and burn it for 6 minutes or 7 minutes. That's how, you burn the fat, you get the taste. That's how you kill anything is good and you cause the disease. Doesn't mean you cannot get even better taste if you actually slow cook that the same way. At 350, it takes a little longer, but actually the taste is better. Trust me, that's how I do it. Focusing on eliminating the natural saturated fat from animal and switching or vegetable source, basically industry loved that, because we have plenty of processed oils, corn, soy, cotton. Crisco, how it came out. In 1920s, they had come up with an industrial process to get from cotton nice oil for candles. They were making candles from that. And then suddenly, electricity came everywhere. There was no more need for candles. What they do with all that stuff? And they switch it basically into margarine, Crisco oil and margarine. And all they had is to advertise enough, particularly to women. It's healthier, it's from vegetables. And basically, that's what we're eating right now. All that processed oil is nothing but what we used to make candles with. Okay, it failed to mention that process, that cottonseed oil is heated about 6 times and you destroy everything. I can tell you, imagine that you're going to eat a burger or french fries after you reuse that oil about 6 times. You get oxidized. While you can change the smell and the taste, you can't change what's oxidized there. It always stays the same way. And that's our problem here. Added trans fat, which is a horrendous problem. Finally, we accepted that, and now it's been completely stopped. So hopefully soon we won't have any more problem with that. And really, even the polyunsaturated fats are not all good. Only the omega-3s and maybe 9s are good. 6s are not good. And I'm talking about pretty much every oil, vegetable oil we have has that a lot. I'll show you the data. And these are the real bad fats in our diet. Why? Because if you hit these guys up, they create aldehydes, which is 200 times more toxic for cancer, diabetes, coronary disease, and dementia, anything you want. All right? And on top of that, so you have the bad fats, they're processed, and then you have the bad carbs like fructose. Combine them together, that's how we got to our epidemic of morbid obesity, insulin resistance, cardiovascular disease, cancer, and dementia. And for those who want to know, okay, which oil is good? So, well, olive oil, everybody likes it, right? Well, here is how you look at it. You have saturated fat, you have monounsaturated fat, and you have the polyunsaturated. The saturated fat, we try to kill it and say it's bad for you for 40 years, but it's very little there. The monounsaturated fat, we don't really have much evidence that it's bad for you. We do have some, but not much. And really, it's the polyunsaturated fat that, what's the problem with the saturation? Well, if it's saturated, you can heat it at higher temperature and it doesn't cause free radicals. But the polyunsaturated or monounsaturated, they have lower melting temperature, so easier to oxidize and create free radicals. And that's acetyl mallory kind of product. So that's a problem. Now, these guys are different. If I were to pick an ideal oil, I would say, well, based on what we learned from Mediterranean diet studies, maybe the flaxseed oil would be the best. Why? Very low saturated fat, monounsaturated fat, and you have a lot of the actual omega-3s there, okay? But there is a catch, and here is the catch. You can call these guys real oils, really good ones to the left. You can get the other ones, fake oils, they're artificial. But if you hit anything over 180, it doesn't matter. You killed everything is good there. So yes, olive oil is good, but don't use it to hit with. And any oil, as a matter of fact, no matter how healthy it is, nuts are great, lots of omega-3s. But you use it cold, it's great. If you use it to heat or grill or burn with it, then you got a problem. Why is broiling or frying bad? Because that requires a temperature of 500 or 550. So at that time, any oil, any fat, doesn't matter how healthy it is, everything is good, is oxidized, and is done. And that's what's bad for us, okay? So take-home message is source is important, how you process it is important, and third, how you eat is important. So what do I tell my patients? All right, well, first of all, you got to cook. I got bad news for you. The industry, the cooking industry, who is the cooking industry? Well, when you actually buy, what they mean by cooking, you buy the frozen food and you warm it up in a microwave for 3 minutes. That's cooking. So even that part, it's only 10% of Americans love to cook if you define that as cooking, which I don't. Basically, just eating up in the. So everybody's worried. Yeah, only 10% cook. Of us cook, and actually most of us don't even know how to cook. All right, and we lost that skill. I say that you can't really change anything until somebody starts cooking. That's the only way how we can potentially become independent from the food industry. So cook is absolutely required for healthy, happy, and long life. As a matter of fact, people who cook are not only healthier but happier and live longer. Basically, Michael Pollan, quotes this in Cooked. Then my patient asked me, okay, what diet would you go for? And really, there is no specific diet that will be necessarily one better than another. You can go any which way as long as it has these rules. Source of food, try to be as natural as possible, as it comes from Mother Nature, pasture, ocean, lake, river. If it's cooked with minimal processing, that means slow cooking. By the way, any taste you ever think you obtain by broiling or frying, you can obtain exactly the same by baking at low temperature. It just takes longer. I promise you, try it. Do the same thing that says fry. Don't do that. Just keep it no more than 350, and it will take you 2 or 3 times longer. You'll see that the food is way tastier. So burning is a problem because it oxidizes the fat, the sugar. So that oxidized fat and sugar, glycosylation, right? And the fat is what causes the disease and early aging. Keep ingredients at natural concentration as found in nature. Anything natural in unnatural amounts equal poison. Do I have to give you any examples? I'll give you an example. Marijuana. Nope, that's not an example. And then you have the concentration of it, which is now vaporized, and people come with marijuana poisoning in the hospital. It's not marijuana. It's actually the compound that's extremely multiplied. But really the same with the sugar. Mediterranean diet is by far, we have so far, if I were to go by the evidence-based medicine, proven for weight loss, lowering cholesterol, cancer, prevent cardiovascular disease. But it's also a lifestyle. It's not just about the diet. If you go in those places, it's based on vegetables, fruits, whole grains, and legumes, but also fish and eggs and some meat too. And again, olive oil, but again, they don't cook at high temperature. They don't fry with it. Lean proteins, chicken, pasture, fish, lots of seeds and nuts. That's extremely important. Great source of omega-3s, the good kind of fat. Beef is okay if it's once a week, not every day. They actually use dairy products. Feta cheese, butter, Irish Kerrygold. Why that? Those are grass-fed, cows. This is available everywhere now at Kroger. What we call Greek-style yogurt is actually a highly natural fermented yogurt that is actually extremely loaded with protein, up to 70 grams of protein per serving, and actually has almost no sugar. So not the low-fat version, which they replace it with sugar. Not the vanilla flavor. No flavor, just the plain. Unfortunately, that's how I grew up. Here, my wife, who grew up here, she doesn't like that because, of course, you've been exposed to a completely different taste. It takes some time to change the taste, but that's what it is. And why? Because it's a source also, not only that, but that fermentation process, source of what we call a good probiotics kind of bacteria, evade any processed food. I tell each and every patient and every human who asks me, the cereals are not food. I'm sorry. Oatmeal is not breakfast. Now, if you're Martian and you're Matt Damon and got nothing else, that's subsistent food. Yeah, go ahead and eat that. But there is nothing nutritional in that. It's zero. It's just 100% junk food. Okay, so that's not breakfast. Eggs are breakfast. You add some vegetables next to it. That's breakfast. Eggs are just basically proteins, a little fat, a lot of good stuff, vitamins and minerals you want, and no carbs. The diet eliminates trans fats and non-pasture butter, margarine, processed food, and red meat. So really, Mediterranean diet is just eliminating processed food diet. Very simple. And somebody has to cook. You buy whatever, however it comes, and you cook. There is no limitation. It's extremely simple. But if you don't cook, you can't do Mediterranean diet. It doesn't matter. You can't do any diet. Or you can't eat healthy. All right? And really, the original, actually, Dr. Malhotra went to the original village. That's actually that Dr. Keyes is the one who actually developed the Mediterranean diet concept, and he's from Payapi village. There are 200 people there. It's called a village where people never die. And average life expectancy is 95 to 100 years. They're healthy and living, active lifestyle up to the moment they die. Is not just eating. By the way, the true Mediterranean diet is actually without pasta and pizza, contrary to what we believe. That's the American version of it because it was a economic requirement back then in the 20s and 30s when Italians migrated and didn't have enough food. All right, includes an active lifestyle with lots of meaningful movement and stress reduction methods. All right, eating vegetables and carbs. How do you eat those? Does it make a difference? Well, here's the deal. I am one of the few who says no. Don't eat 3 apples a day. 1 apple a day, keeps the doctor away. It's true up to a point. Why? 1 apple is 8 teaspoons of sugar. So if you juice the apple, all that is released. You just have 8 teaspoons of sugar. If you're pre-diabetic or obese or you're going to lose weight, you have to. Do you know how much workout you have to do for that? To burn those 8 teaspoons of sugar, the calories that come from that, you'll have to do about 3 hours of treadmill at 6 miles an hour a day. Just 1 apple. So it's not. However, if you eat the apple, most of the sugar, actually at least half of the sugar is not available. It's not bioavailable because it binds to the fiber. It goes into your large bowel, and then it's actually food for the healthy bacteria. So, like Dr. Rob Elastic says, Mother Nature came with the poison and the antidote. Is when you separate the nutrients, the nutritionalism, and you think if you had the nutrients separate in a tube, it's going to create the same thing. No, they got to be together as they were packaged by Mother Nature. That's what makes a difference. Don't juice the apple, eat it. Okay, if you really want to eat. Okay, and don't juice the vegetables either. Why? Because once you smoothie and juice, you just destroy the fiber. That's actually what protects us from binging too much of the bad stuff. You don't want to get rid of the fiber. And the fiber that we have at Walmart or at Kroger, the metamucil, is not real fiber. That's soluble fiber. We're talking about the insoluble fiber. It makes a difference. That doesn't do anything. That's why you can make your patients take 27 grams of that. They'll tell you, it never helped me with my constipation. No, it doesn't. It's not the same thing. It's soluble, right? You got to put water so you can drink it. So slows down the absorption of sugars and provides food for beneficial bacteria to make short-chain fatty acids. That's food for the healthy bacteria that protects us against colon cancer, our immune system against other body's cancer. As a matter of fact, our 2/3 of our whole immune system, it's in that large bowel. I know I'm going over time, but I hope I'm not boring you, all right? But if I go too fast, then we lose the message here. So it is more important than we think what we eat and what goes to those healthy bacteria. And we call them now probiotics. And actually, you can just buy cultural and we give it in the hospital. What's wrong with that? Well, they got to eat. So if you keep eating your burger, the prebiotics, and you don't eat what they are fed with, or if we give them antibiotics every other day, we just kill those guys anyway. They got nothing to eat because unless you change, you can take the probiotics, but unless you change what you're eating so they have something to eat, it doesn't matter. Or if you keep using the antibiotics for whatever reason doctor recommends, you just kill those guys anyway. So what's the point of taking cultural by itself? Eat lots of leafy vegetables, fiber, very important. If you juice, I use 3-to-1 ratio. I tell them, okay, there's no other way you get your vegetables, go ahead, juice mildly, or smoothies, and use fruit just 1 ratio just to give it some taste, and 3 times should be more the vegetables. What about coffee? We tell our patients coffee is great, no problem with that. I mean, cardiologists try to nail it. Only if you have 5 coffees a day, you get arrhythmias, you get other issues. 2 a day is fine. And by the way, is the single most important drug we have for fatty liver, and the liver guys know this. It's proven. It's caffeine. All right, and theophylline from the tea is an example of natural plus unnatural amount is unnatural, and you need moderation. So lately you're going to see a lot, and you're seeing patients ask me, how about stevia? Coca-Cola has a whole line of products. Pepsi has, every soda company is going into having a lot of products with stevia. Why not stevia? Because it's wrong. They don't care. So what if it's natural? I mean, everything we have that we drink, including sugar, is natural. But there's a difference between 1 teaspoon of sugar and equivalent of 30 teaspoons of sugar. Why? Because anything over 8, you get diabetes. It doesn't really matter. You could have less calories, not about calories. What I want my patients is to change their sweetness index. I don't want them to crave sweet no more. They need to change that. So you need to lower the sweetness index. They need, like any addiction, to go cold turkey. That's the only treatment that works. So no. In apple juice, equivalent of 8 teaspoons of sugar. Orange juice, 8 or higher. Cranberry, I'm talking about not from concentrate. I'm not even talking about the one. It's not the one that you juice. The one you juice, it's equivalent of 3 teaspoons of sugar, just 12 grams. Okay, with 1 teaspoon is 4 grams. Cranberry juice, 8 teaspoons of sugar. They add it up. So, and you don't have basically any fiber there. So source of food is most important. Second factor. Second is how you cook. Third, by avoiding processing and frying. Third is how we eat. Okay, and I don't think I'm going to be able to go through all that. I'm already way over time, and I'm sorry for that. But I will, though, make one point is a lot of my patients, they ask me, how about vegetarian? Okay, how about vegetarian diet? What do we know about vegetarian diet? We have some studies of plant-based food. This is actually Dr. Esselstein's. He had 198 patients, 4 years on a plant. And this is extreme plant diet. What I mean is no oils, no fat, this would be the super low fat diet and the super and highly carb based but unprocessed carbs. That extremely basically no oils, eliminated completely. In 4 years on plant diet, these are patients who continue. Some of them 22 continue with regular Western diet based on their choice, and the ones who actually 170 who did plant-based diet, only 0.6% develop another cardiovascular disease. These are patients who were not, they couldn't undergo CABG. This is end-stage coronary disease. There was no other options. That's why they took this option. Okay, and only 0.6, whereas 64% from the one on regular diet developed cardiovascular outcomes. 30-fold difference. So we have some data there. Okay, we have some data, and I didn't get a chance to talk about how can we get to what is the mechanism of resistance to changing the diet. And I would encourage you, if you get a chance, to read this book, The Hacking of the American Mind. It's not a political book. There's nothing conspiratory there. It's talking about the basic mechanisms of food addiction, okay, and state-of-the-art science. This is not a non-scientific book, okay? And he has actually about 4 C's there to say how to change people, to change their lifestyle, to incorporate this. They need to connect, they need to contribute, they need to cope, and they need to cook. And cope, particularly the sleep, mindfulness, and exercise, is extremely important. So I'm going to summarize this. Like Michael Pollan said, eat food, mostly plants, and not too much. Okay? And thank you for putting up with me for a good 1 hour and 15 minutes.